If you're watching this video, the chances are that someone, a GP or a cardiologist, or perhaps even a family member, has said the words, "You may need heart surgery." And right now, you might be very frightened, confused, or perhaps even angry, particularly if you've been waiting many months for an appointment. And maybe you've been looking on the internet, searching the guidelines to try and understand more about your heart condition, and you just can't make any sense of the Google searches. If any of this resonates with you, you're in the right place, and this video hopefully will deal with a great deal of the fear and the confusion. So who am I? My name is Inder Birdi. I'm a cardiac surgeon, and for the last 35 years I've been treating people in the United Kingdom. I've sat across thousands of patients in my clinic, exactly in the same position as you and your family. And the first thing I want you to know is this: asking the question, do I need heart surgery? Or better still, why do I need heart surgery? Is not a sign of doubt. It's an extreme sign of intelligence, and it's the right set of questions that you should be asking. And you deserve complete and honest answers. So I'm going to try and help you today in this video. First of all, let me explain what heart surgery actually covers, because it's broader than most people realize. The three most common reasons people need heart surgery are valve-related disease, either the valve is blocked, stenosis, or leaking, regurgitation; coronary artery disease, these are blocked heart arteries causing angina or heart attacks; aortic diseases, where the main artery becomes dangerously enlarged, like an aneurysm. And these account for the vast majority of what we do, but there are other reasons that we operate. For example, we can operate to close holes in the heart. These are defects that some people are born with, and they may not be discovered until adulthood. We correct other congenital abnormalities. These are structural problems that were there from birth, but only become significant later in life. We can remove cardiac tumours, growths within the heart that are often benign, but obstruct blood flow through the heart, and they can throw off clots. And we also perform certain types of surgery for heart rhythm problems like atrial fibrillation. These are problems that sometimes can't be controlled with medicines or catheters alone. So the range is wide, but today I want to focus on the most common situations, because these are the ones most of you watching will actually be facing. And the critical thing to understand is that do I need heart surgery depends entirely upon the condition that you have, how severe that condition is, and what it is actually doing to your heart. And this is where it gets really nuanced, and where guidelines alone, when you read them on Google or in the internet, really can't help you. You need specialist teams to answer these questions for you. And I think this is often where we as doctors sometimes let patients down. They're often given a diagnosis, but not really told what that diagnosis actually means for them. Let me give you some examples. If you have severe mitral valve regurgitation, this is a badly leaking mitral valve, current guidelines recommend surgery even if you have no symptoms, even if you feel perfectly well. Now, why would that be? Because by the time symptoms appear with mitral valve regurgitation, the heart muscle may have already sustained damage that is difficult to reverse. With mitral valve disease, early repair before the heart changes shape gives you the best possible long-term result, and of course prevents you from getting other problems like atrial fibrillation. Now compare that with severe aortic valve regurgitation, a leaky aortic valve. Here the picture is very different. Many patients with severe aortic regurgitation can be managed conservatively. In other words, watched very carefully, sometimes for many years before they actually need surgery. We monitor them with regular scans called echocardiograms, and we intervene when symptoms develop or when we see that the heart is beginning to enlarge. The timing is very different because these diseases behave very differently. Then, of course, there's severe aortic valve stenosis, a narrowed aortic valve. It's a very common condition. This, when it becomes symptomatic, is a life-threatening condition. Once symptoms develop, breathlessness, chest pain, blackouts, survival without treatment is measured in months, not in years. You've got a 50-50 chance of dying within 2 years with that condition. Aortic stenosis is a condition where early treatment genuinely saves lives, and delay can be fatal. Let's think now about coronary disease, and this is equally specific. A narrowed heart artery with no symptoms may need further investigations like a stress test or a CT scan or a functional assessment to determine whether surgery or stenting is the right approach. But critical narrowing high up in the left main coronary artery, called the left main stem, which we actually in medicine call the widowmaker's lesion, even in the absence of symptoms, needs urgent surgery, even if you feel completely fine, because the risk of a sudden catastrophic heart attack is just too great to wait. So you can see that the same word severe means very different things depending on which part of the heart is affected. And that is why blanket answers to the question, do I need heart surgery, is really impossible to answer. And that's why when you read guidelines, you're going to find it very difficult to understand. Now, many patients ask me, I feel fine, surely I don't need surgery. And I understand that instinct. If you feel well, the idea of someone opening your chest feels a little bit absurd, for sure. But here is what you need to understand. Sometimes symptoms are not always the reliable guide. Some of the most dangerous heart conditions, a critically narrowed left main stem artery, the widowmaker's lesion, or a rapidly enlarging aortic aneurysm, or a severely leaking mitral valve, or aortic valve stenosis, can be completely silent until something catastrophic happens. And the heart is remarkably good at compensating for a long time before it finally, one day, just gives up. Eventually, some patients will get symptoms if they're lucky, and those symptoms will usually be things like breathlessness, fatigue, chest tightness, dizziness, or just simple lethargy. So symptoms do matter, but they're only one piece of the puzzle and not the whole picture. And that is why a decision about surgery should never be made on symptoms alone, and never be dismissed because symptoms are absent. So if the decision is this complex, how is it actually made? In many responsible cardiac centres, the question about whether you need surgery or not is made not by one person. It's actually made by a multidisciplinary team. We call this the MDT. Now that team typically consists of a cardiac surgeon, a cardiologist, an anaesthetist, and a cardiac imaging specialist, usually multiple specialists in each of those disciplines. Sometimes we might need a cardiac physiologist or a specialist nurse. Your scans, your blood tests, your symptoms, your other medical conditions, your age, your fitness, your wishes, these are all reviewed and put together, and the team reaches a consensus, not one surgeon's opinion, but a collective evidence-based recommendation that is entirely specific to you. And this is not a rubber stamp exercise. This is about engaging with you what we think might be the best way forward to give you the opportunity to understand what the options are and what your preferences are. I've been in MDT meetings where the cardiologist recommends surgery, where the imaging changes the entire plan, where a patient's other conditions make the risk calculations completely different from what it would be for someone 10 years younger. And that's the process. It's a really educated environment, far more powerful than a Google search. And it's actually designed to protect you, to make sure that no one operates on you unless the evidence, the expertise, and the team all agree that it's the right thing to do. But there is one more member of that team who is often forgotten, and that's you. Your choice must be part of this decision. And so your surgeon will often ask you what your preferences might be before they present your case to the MDT. Not as an afterthought, not as a signature on a consent form, but as a genuine informed participant in the conversation about your own heart. And that means you need to understand what is wrong, what the options are, what the risks are, and what happens if you choose to wait. And that means that your surgeon needs to listen to your concerns, your priorities, and to what really matters to you beyond just survival. Some patients prioritize getting back to work more quickly and they prefer minimally invasive surgery. Some patients prioritize avoiding blood thinners if they need a heart valve replacement. And some simply need more time to process the difficult environment and the circumstances that they found themselves in. And all of this is valid, and all of it should shape the plan. Because the best surgical decision is not just the one that is medically correct, it has to be the right one for you. And here is something that I want to leave you with, because it genuinely changes the equation for many patients. One of the reasons people fear heart surgery is the image they carry in their mind, the split breastbone, the long scar, the months of recovery. And I understand that fear because for decades that was the reality. But today in experienced centres, the majority of heart operations, valve repairs, valve replacements, bypass grafts, heart rhythm disturbance operations, closing holes in hearts, these can all be performed through small incisions. We call them minimally invasive or keyhole incisions, without having to break the breastbone, so there's no large scar and recovery is very quick. The difference is not cosmetic, and that's the most important thing. It's clinical. Less pain, less blood loss, lower infection risk, and a dramatically faster recovery. But whether or not you need breastbone surgery or you need keyhole surgery, treating the condition early means the risk will be low and the recovery will be quick, and the optimization of your long-term future will be maximum. Now, keyhole heart surgery is not right for everyone. It does require specific expertise, specific equipment, and specific decision making. But if you are a candidate, and many patients are, by the way, it can transform heart surgery from something you dread into something you can recover from very quickly. So, do you really need heart surgery? I can't answer that question entirely in this video, but I hope that I've shown you that the answer is never simple, never generic, and never something you should accept without an understanding as to why. You deserve to understand your condition, you deserve to know your options, and you deserve a team that will be honest with you and a surgeon who will listen to you. If this video helps even a few people understand their hearts a little better, or gives someone the confidence to seek advice sooner rather than later, it will have been entirely worthwhile. If you would like to discuss your own case with one of our team or with me, click the link below to the Decision Clinic. It's in the description. There's no commitment, there's no GP referral required, just clarity. Thank you for watching.